Firstly, head to medsynclimited.com and get the Plastic Surgery Board Exam Revision ANKI deck with over 7,000 questions arranged by topic, covering every topic of the plastic surgery curriculum. This will turn passive reading and revision into active recall. Based on the textbook Keynotes in Plastic Surgery, it is the go-to companion exam question guide.
Absolutely. It's just an essential tool.
Yeah. So, state the mission directly. This is a board exam revision deep dive. We are functioning as a chapter summary designed specifically for you, the resident preparing for the FRCS in plastic surgery or similar board exams.
Right. High yield, no fluff.
Exactly. I'll be rapid firing the high yield board questions. My counterpart here, who is also a plastic surgeon, will provide the comprehensive examiner level explanations. So you get the question, you get the deep clinical reasoning.
I am ready when you are.
Okay, let's unpack this. We are diving into cutaneous oncology, vascular anomalies, and soft tissue tumors. And usually, when we talk about a surgical diagnosis, there's an expectation of binary precision. It's benign or it's malignant. Oh, if only it were that simple.
Right. But in cutaneous oncology, the waters are completely muddy.
Yeah. It's the absolute definition of diagnostic muddy waters. And board examiners, they love to drown you in them.
They really do.
Because every board exam tests your ability to differentiate the benign imitators from the actual malignant threats.
Right.
If you misclassify a lesion, you either subject a patient to deeply unnecessary disfiguring surgery or, much worse, you leave a lethal cancer behind to metastasize.
So we have to secure that foundational knowledge of benign lesions first and their associated genetic syndromes. Let's start with a classic clinical trap.
Okay.
An elderly patient walks into your clinic. Over the last 6 weeks, this massive, ugly nodule has erupted on their cheek. It looks really angry. How do we differentiate a keratoacanthoma, KA, from a squamous cell carcinoma clinically? And what exactly is the pathologist seeing under the microscope?
Right. So clinically, your primary differentiator is the timeline. And the morphology, of course.
The rapid growth. Exactly. A keratoacanthoma is characterized by incredibly rapid evolution. We are talking about a lesion that erupts over a matter of weeks, or maybe a couple of months, into this distinct dome-shaped nodule.
And it has that core, right?
Yeah, right in the middle, it has this classic central crater-like keratotic core. It literally looks like a tiny volcano on the skin.
So that's the KA.
But, crucially, if you leave it alone, it undergoes spontaneous involution. Usually within about 4 to 6 months, the immune system kicks in, the core falls out, and it regresses. It leaves a depressed, slightly puckered scar.
Which an SCC definitely does not do.
No, absolutely not. A true squamous cell carcinoma, an SCC, does not spontaneously involute. It just relentlessly and progressively destroys local tissue.
But here's the problem we face in real life and on the boards. I can't just tell an anxious patient, let's just watch this ugly facial tumor for half a year and see if it falls off.
Obviously not.
Right. And when I biopsy it, the histology report is often incredibly frustrating. The pathologist almost always hedges. Why is it so notoriously difficult to differentiate a KA from an SCC histologically?
Because under the microscope, the cellular architecture is remarkably similar. Both feature proliferating squamous cells with atypical nuclei and mitotic figures.
So they look identical at the cellular level?
Essentially, yeah. In fact, many pathologists maintain that KAs aren't even a distinct biological entity.
Wait, really?
Yeah. The prevailing thought in dermatopathology right now is that a KA is simply a well-differentiated squamous cell carcinoma that just happens to have a biological tendency to regress.
That makes a lot of sense.
So when the pathologist looks at a core biopsy, they're just seeing a snapshot of highly active atypical keratinocytes. Without seeing the entire architecture of the lesion, that classic lipping of the epidermis over the central crater, they can't confidently rule out an invasive SCC.
Which is why the definitive treatment is usually complete surgical excision. Betting on spontaneous regression when the pathologist is hedging is not a winning oncological strategy.
Definitely not. You cut it out.
Okay, let's pull back and look at the systemic picture. If a patient presents not just with one KA, but with multiple KAs popping up all over their body, what genetic bells should be ringing in your head?
You must immediately think of two major familial syndromes: Ferguson-Smith syndrome and Muir-Torre syndrome.
Let's do Ferguson-Smith first.
Okay, Ferguson-Smith. This is linked to a single gene mutation on chromosome 9. It's an autosomal dominant condition, and it presents with multiple eruptive self-healing epitheliomas.
Which are basically KAs.
Exactly. They look, behave, and resolve exactly like classic KAs.
And there is a very specific epidemiological trivia point examiners love to test regarding Ferguson-Smith, right?
Uh,
The ancestry thing.
yes, it's a classic board question. Most of the patients with Ferguson-Smith syndrome can trace their ancestry back to a single family living in Western Scotland in the 18th century.
So it's a founder effect.
It is a textbook example of a genetic founder effect. If the clinical vignette mentions a patient of Scottish descent with multiple self-healing skin tumors, you click Ferguson-Smith and move to the next question.
That is exactly the kind of esoteric detail that separates a pass from a fail. But let's talk about the other one, Muir-Torre, because that one is truly a matter of life and death. How does that present?
Muir-Torre syndrome is critical. It links these relatively harmless cutaneous lesions to lethal internal malignancies. Like Ferguson-Smith, it is autosomal dominant in about 2/3 of cases.
But the mechanism is different.
Very different. The underlying mechanism is what matters. It's driven by a germline mutation in the DNA mismatch repair genes. Specifically, you need to know HMLH1 and HMSH2.
To clarify for the listener, mismatch repair genes are essentially the spell checkers for our DNA. When cells divide, DNA polymerase makes mistakes.
Right, it's a messy process.
Yeah, so if HMLH1 or HMSH2 are mutated, the spell checker is broken, mutations accumulate rapidly, and cancer develops.
Exactly. And the classic cutaneous presentation of this broken spell checker is one or more sebaceous neoplasms, like a sebaceous adenoma, sebaceous epithelioma, or sebaceous carcinoma, or, multiple KAs.
But the skin lesions aren't the real danger.
No, the cutaneous tumors are just the smoke. The fire is that these patients have a massive risk of visceral malignancies, most commonly gastrointestinal carcinomas like colorectal cancer or genitourinary carcinomas.
Which goes back to my opening scenario. If you excise a strange sebaceous tumor or see a patient with multiple KAs, you cannot just discharge them.
Never.
You must refer that patient for a rigorous GI and GU workup. Missing that connection and failing to order a colonoscopy is a catastrophic failure on the board.
It shows a lack of safe systemic practice, honestly.
Yeah.
And this perfectly transitions us to another dermal lesion, where the skin manifestation is just the tip of the systemic iceberg. Let's discuss Cowden's disease.
Right, Cowden's disease. I always remember the facial papules, but examiners aren't just testing our dermatology knowledge here. What is the underlying mechanism, and what are the specific diagnostic criteria we need to look out for?
Cowden's disease is another autosomal dominant condition. The underlying biological mechanism is a germline mutation in a crucial tumor suppressor gene called PTE.
PTEN.
Correct. When PTEN is functioning normally, it regulates cell division. It prevents cells from growing and dividing too rapidly. When it's mutated, you get hematomatous overgrowth everywhere.
And the skin findings?
The mucocutaneous lesions are practically universal in these patients. Over 90% of them develop facial tricholomomas.
And what exactly does a tricholoma look like clinically?
They are small, benign, skin-colored, warty papules. Usually they're clustered around the mouth, the nose, and the ears. They arise from the outer root sheath of the hair follicle.
Are there other skin signs?
Yeah, patients with Cowden's also frequently develop acral keratoses, which are thickened skin lesions on the hands and feet, and oral mucosal cobblestoning.
Right, which gives the inside of their mouth a bumpy texture. But again, the facial tricholomomas equal a PTAN mutation, which equals an aggressive hunt for internal disease. What are we hunting for here?
You're hunting for a massive risk of internal hematomas and aggressive carcinomas. These patients have a significantly elevated lifetime risk of breast carcinoma, endometrial carcinoma, and thyroid carcinoma.
Breast, endometrial, thyroid.
Exactly. They also develop hematomatous polyps throughout their intestinal tract. So if a board question describes a patient with warty facial bumps and a family history of breast or thyroid cancer, they are begging you to diagnose Cowden's disease and PTEN mutation.
Okay, let's change gears slightly to a completely different demographic. You are called to the pediatric emergency room. The parents are terrified because their 6-year-old child has developed a solitary, rock-hard lump on their cheek.
Classic presentation.
Yeah, it feels like a literal stone sitting under the skin. How does a pilometrosoma present, and what is the biology there?
A pilometrosoma, which historically was known by the rather dramatic name calcifying epithelioma of Malherbe.
I love those old eponymous names.
They're great.
Right.
It also arises from the outer root sheath cells of the hair follicle. The presentation you just described is classic. It's almost always a solitary subcutaneous nodule, overwhelmingly found on the face, neck, or upper arms of children.
Mostly kids, then.
Yeah, in fact, 40% of these develop in the very first decade of life.
And why does it feel like a pebble? Why is it so hard?
Because as the tumor cells proliferate, They undergo a specific type of mummification or ghost cell formation, and they frequently undergo intense dystrophic calcification or even actual ossification. They turn to bone.
Wow. And genetically, if they ask you for the mutation on the boards,
Genetically, 75% of these tumors harbor mutations in the CTNNB1 gene.
which codes for beta-catenin, right? A key player in cell signaling and adhesion.
Correct. But despite the scary, rock-hard presentation and the genetic mutation, the clinical takeaway for the boards is that malignant change is exceedingly rare.
So simple excision.
Simple, complete surgical excision is entirely curative. You just shell it out.
Perfect. Let's shift our focus to pigmented lesions, specifically congenital melanocytic naïve, or CMN. This is an area where our fundamental understanding of risk has drastically evolved. First, for the sake of the exam, what is the actual strict definition of a giant CMN?
A giant CMN is defined not by its size at birth, but strictly by its projected adult size.
Oh, that's a key distinction.
It is. If the lesion is projected to be greater than 20 centimeters in maximum diameter when the patient reaches adulthood, it is classified as a giant CMN. They are quite rare, with an annual incidence of about 1 in 20,000 births.
The management of these giant lesions has undergone a massive paradigm shift in recent years. I mean, I remember reading older textbooks where the quoted lifetime risk of a giant CMN transforming into a melanoma was terrifyingly high.
It was. Historically, the literature quoted melanoma risk as high as 40 to 45%.
Which is absolutely terrifying for parents. I mean, if you tell a parent their newborn has a 45% chance of developing a deadly skin cancer, they will beg you to cut it out immediately, regardless of the cosmetic or functional cost.
And that profound fear drove decades of highly aggressive prophylactic surgical excisions in tiny neonates.
Huge operations.
Massive. Surgeons were taking babies to the operating room to excise these massive tracts of skin, requiring complex tissue expansion, enormous skin grafts, and just subjecting neonates to significant physiological stress and blood loss.
But the data doesn't support that anymore.
Not at all. Modern, large-scale prospective registry data has completely debunked those older numbers. The actual evidence-based lifetime risk of malignant change within a CMN is much, much lower. It's currently estimated to be between 0.7% and 2.4%.
That is a staggering difference, from 45% down to around 1 or 2%.
It changes the entire surgical calculus. Furthermore, the data shows that if a melanoma is going to develop in these patients, it usually doesn't happen in adulthood. The median age of melanoma diagnosis in a patient with a giant CMN is around 7 years old.
Interesting.
Because of this new data, the multidisciplinary team approach, like the protocols pioneered at Great Ormond Street Hospital, has completely changed.
I really want to push back on the old logic of prophylactic neonatal surgery because I think it highlights an outdated understanding of melanocyte biology.
Jared.
There's a beautiful analogy used in the texts where melanin acts like a microscopic sunshade. Let's look at how elegant this system is. The melanin pigment is produced deep down in the melanocyte. It gets packaged into these little transport vehicles called melanosomes.
Right.
The melanocyte then reaches out with these long, spider-like dendritic processes and physically injects the melanosomes into the surrounding superficial keratinocytes.
It's incredible cell-to-cell transfer.
Yeah. And once inside the keratinocyte, the melanin doesn't just float around randomly. It literally orchestrates itself to sit directly over the external-facing apical surface of the cell's nucleus. It acts like a physical, chemical sunshade to absorb UV radiation before it can damage the DNA inside.
That is a brilliant physiological defense mechanism.
Yeah.
It's highly coordinated cellular teamwork.
Exactly. But regarding CMN, there used to be this deeply flawed biological theory driving surgery. It was called the Abtropfung theory, dating all the way back to the 1890s.
The drop-off theory.
Yeah. The theory proposed that all nevus cells start out very superficial at birth, sitting right at the epidermal junction. And then over years, they slowly drop off or migrate deeper into the dermis. So pediatric surgeons thought, hey, if they're all superficial right now, if we just dermabrade or curette the top layer of the newborn skin in the first few weeks of life, we can scrape away all the nevus cells and prevent cancer forever.
And we now know that is biologically false. The Abtropfung theory is entirely obsolete. The nevus cells in a giant CMN are not just superficial. They extend deep into the dermis, into the subcutaneous fat, and sometimes even into the underlying fascia or muscle from the exact moment the child is born.
So if you perform a superficial curettage on a neonate, what are you actually accomplishing?
You are accomplishing nothing oncologically, and you are causing massive harm. First, You face a terrifyingly narrow window of permissible blood loss in a neonate when you scrape off a massive surface area of skin.
Babies don't have a lot of blood to spare.
No, they do not. But worse, you leave millions of residual NIBA cells deep in the dermis, and then you cover them up with a thick layer of rigid scar tissue from the dermabrasion.
Which means if a melanoma does start to develop deep down 10 years later, you will never be able to see it clinically because it's hidden under a sheet of scar. You've made clinical monitoring impossible.
Precisely. You've blinded yourself to the cancer.
Plus, if the overall risk is only 1 to 2%, and we know that a significant proportion of melanomas in these patients arise completely outside the cutaneous CMN or even internally in the central nervous system as leptomeningeal melanosis, then doing prophylactic neonatal surgery seems like a high-risk gamble for an oncological myth?
It is exactly that. It's a gamble we no longer take.
Yeah.
The modern board answer for a giant CMN is clear. Multidisciplinary team involvement. Serial, high-quality clinical photography to monitor for changes.
Like imaging?
Yes.
Yes.
An MRI, screening of the brain and spine before 6 months of age for high-risk patients. Those are the ones with multiple satellite naivia or lesions over the posterior axis. We do the MRI to check for neurocutaneous melanosis. And we emphatically postpone any routine or cosmetic surgery until after the child is at least 1 year old.
Because the anesthesia risk drops.
Exactly. By age 1, the physiological risks of general anesthesia are significantly lower, and the child's blood volume can better handle the surgery. We operate for functional reasons, or for severe cosmetic distress later in life, but not purely to chase a 1% oncological risk in a newborn.
That is a phenomenal breakdown. Okay, we spent a lot of time on the benign simulators and the rare syndromes. Now we need to transition to the bread and butter of cutaneous oncology.
The daily grind.
Yeah, these are the malignancies you will see every single day in clinic. The basal cell and squamous cell carcinomas. These are the most common malignancies in the Western world, bar none. This is where your knowledge of highly specific surgical margin guidelines will be heavily tested by the examiners.
Absolutely.
Let's look at basal cell carcinoma, BCC. What is the genetic pathogenesis, and how do we classify surgical margins based on the NICE guidelines?
To understand the margins, you really have to understand the biology. BCC pathogenesis is primarily driven by cumulative, lifetime exposure to ultraviolet radiation, specifically the UVB spectrum.
Right, UVB causes the DNA damage.
Yes. This radiation induces DNA damage and specific mutations in crucial tumor suppressor genes. The two most important ones you must know are P53, the guardian of the genome, and PTCH1.
PTCH1, what happens when that is mutated?
Well, PTCH1 normally acts as an inhibitor of the hedgehog signaling pathway. This pathway is absolutely crucial during embryonic development to tell cells where to go and how to differentiate. But it should be largely silenced in adult tissues.
So it's supposed to be turned off?
Right. When PTCH1 is knocked out by UV damage, it can no longer inhibit the pathway. The hedgehog pathway becomes constitutively activated. It gets stuck in the on position, driving the uncontrolled, relentless basal cell proliferation that we see clinically as a basal cell carcinoma.
This perfectly explains why patients with Gorlin syndrome are in so much trouble.
Exactly. Gorlin syndrome, also known as basal cell nevus syndrome, is an autosomal dominant condition where the patient inherits a germline mutation in one of their PTCH genes.
So they're born with one hit already?
Yes, because all their cells already have one hit to the pathway. It takes very little UV exposure to knock out the second copy. Consequently, these patients develop dozens, sometimes hundreds, of BCCs at a very early age, often in their teens or 20s.
And examiners will definitely want to know the other diagnostic criteria for Gorlin syndrome. It's not just the skin cancers, is it? We are looking for systemic developmental anomalies because that hedgehog pathway is disrupted from birth.
Precisely. If you hear Gorlin syndrome in a prompt, you must immediately recall the clinical checklist. First, multiple early-onset BCCs. Second, palmar and plantar pits.
What are those?
These are tiny pinpoint depressions on the hands and feet caused by localized absences of the stratum corneum. Third, odontogenic keratocysts, which are destructive cysts in the jaw, and examiners love to ask. They are more common in the mandible than the maxilla.
Mandible over maxilla, got it. What else?
Fourth, skeletal anomalies like bifid ribs or splayed ribs. Fifth, ectopic calcification, specifically calcification of the falx cerebri, which you can see clearly on a skull X-ray. And finally, a significant risk of central nervous system tumors, particularly medulloblastoma developing in early childhood.
Okay, so we understand the genetics and the syndromic presentations. Now, the practical surgery. A standard patient comes in with a BCC. How do we cut them out? What are the exact surgical margins we must take?
The surgical margins depend entirely on how we risk stratify the tumor based on clinical and histological features. Let's start with low-risk BCCs.
What defines low risk?
A low-risk lesion is defined as being less than 2 centimeters in diameter, having well-defined clinical borders so you can easily see where the tumor ends and normal skin begins, and being located in a non-critical anatomical area, like the trunk or the limbs. For these, the standard UK guideline is a 4 mm peripheral margin of normal skin.
And the deep margin?
The deep margin should always include a layer of macroscopically normal subcutaneous fat. You do not just scrape the dermis. Taking that 4 mm peripheral margin and a layer of fat clears the microscopic tumor roots in about 95% of cases.
But 4 millimeters is completely inadequate for high-risk lesions. What upgrades a BCC to high-risk status?
A BCC becomes high risk if it has poorly defined clinical borders, if it is a recurrent lesion that has already failed previous treatment, or if the initial biopsy shows an aggressive histological subtype.
Like what subtypes?
The aggressive subtypes you must look for on the pathology report are infiltrative, morphaic, or micronodular. These subtypes don't grow in a neat little ball. They send out long, invisible microscopic tentacles far beyond the visible edge of the tumor.
ANKI.
Very. For these high-risk lesions, you must take at least a 5 mm peripheral margin. And even with a 5 mm margin, your incomplete excision rate jumps significantly because those microscopic tentacles are just so unpredictable.
This is exactly why, for high-risk lesions, especially in cosmetically or functionally sensitive areas like the central face, the eyelids, or the nasal ala, Mohs micrographic surgery is the absolute gold standard. Mohs surgery is a concept you have to be able to explain clearly and vividly to an examiner.
How do you usually conceptualize it for the residents?
The text has a great visual analogy for this, comparing traditional pathology to Mohs. Think about traditional histopathology. When you send an ellipse of skin to the lab, the pathologist uses a technique called bread loafing.
Right, slicing it up.
Yeah, they take your specimen and make vertical slices through it, just like slicing a loaf of bread. They mount those few slices on slides. Because they're only looking at thin intervals, they might only be evaluating 1% to maybe 40% of the actual surgical margin. You are basically crossing your fingers and hoping that a microscopic finger of tumor hasn't slipped through the gap between two slices.
It is an inherently flawed sampling technique for aggressive tumors.
Exactly. Mohs micrographic surgery is entirely different. Imagine taking a shallow, disc-shaped bowl of tissue out of the patient. Instead of slicing it vertically, the Mohs surgeon takes that bowl, makes relaxing incisions in the edges, and squashes it completely flat on the slide. Then they freeze it.
So they see the whole edge.
Yes. When they slice it horizontally, parallel to the skin surface, they are looking at the absolute outermost layer of the entire specimen. They get to look at 100% of the deep and peripheral edge all at once. If there's a positive spot of tumor at, say, the 3 o'clock position, the surgeon goes back to the patient and takes a tiny bit more tissue only at the 3 o'clock position, sparing all the healthy tissue at 9 o'clock.
It's an incredibly labor-intensive, time-consuming technique. The surgeon is acting as their own pathologist, but it provides the highest possible cure rates approaching 99% while maximally preserving normal healthy tissue in critical areas where every millimeter counts, like the eyelid margin or the nasal tip.
Let's move from BCC to cutaneous squamous cell carcinoma, SCC. It is the second most common skin cancer, but it behaves very differently. What are the high-risk features for an SCC, and what is the surgical management protocol?
The critical difference is that while BCCs cause massive local destruction but rarely spread, SCCs have a very real potential for both aggressive local destruction and distant metastasis, primarily to the regional lymph nodes.
Do they spread?
Yes. Because of this metastatic potential, our risk stratification has to be much tighter. The high-risk features for an SCC are defined by a combination of clinical and microscopic parameters.
What are the clinical red flags?
Clinically, any tumor greater than 2 centimeters in maximum diameter is high risk. Furthermore, the anatomical site is vital. SCCs located on the ear or on the non-hair-bearing mucosa of the lip have a significantly higher rate of metastasis and are automatically considered high risk.
And under the microscope, what is the pathologist warning us about?
Microscopically, the absolute depth of invasion is critical. An SCC with a depth of invasion greater than 4 millimeters, or any tumor that extends down into the subcutaneous fat or deeper, significantly increases the risk of recurrence and nodal metastasis.
What about the grading?
You must look at the histological differentiation. Tumors are graded by how closely they resemble normal squamous cells. This is the Brodder's grading system. A well-differentiated tumor is Brodder's grade 1. But a poorly differentiated tumor where the cells look wild and chaotic, what we call Brodder's grade 3 or 4, is highly aggressive.
Any other path features?
Finally, if the pathology report notes perineural invasion, meaning the tumor is tracking along nerve sheaths or lymphatic or vascular invasion, that automatically upgrades the risk profile, regardless of size.
And how does that complex risk profile translate into our surgical margins? What are the numbers we need to memorize?
It is relatively straightforward once you stratify them. For clinically well-defined, low-risk SECs, meaning they are less than 2 centimeters, not on the lip or ear, and not deeply invasive, a 4-millimeter margin of normal tissue is acceptable.
And for high risk?
The moment you have even a single high-risk feature size over 2 centimeters, poor Brodder's differentiation, depth over 4 millimeters, or a high-risk location, you must upgrade your minimum surgical margin to at least 6 millimeters.
Before we leave the non-pigmented lesions, there is a rare one that examiners love to use as a trap. What makes Merkel cell carcinoma, MCC, genetically unique, and how aggressive does our surgical approach need to be here?
Merkel cell carcinoma is rare, but it is a fiercely aggressive neuroendocrine carcinoma of the skin. Clinically, it often presents as a rapidly growing, painless, firm, purple-red or violaceous nodule, usually on the sun-exposed head and neck of elderly patients.
And the genetic?
What makes it genetically fascinating and unique among skin cancers is that approximately 80% of cases are directly linked to a viral infection, the Merkel cell polyomavirus, or MCPYV. The viral DNA integrates into the host genome and drives the oncogenesis.
And why is it a diagnostic trap for the pathologist?
Because under the microscope, MCC is a classic small blue cell tumor. It looks incredibly similar to a metastasis from a small cell lung cancer. If an elderly patient has a small blue cell tumor on their skin, you have to figure out if it started in the skin or if it spread from their lungs.
How do they tell the difference?
To differentiate it, the pathologist must use specific immunohistochemistry stains. The classic board answer is that Merkel cell carcinoma is characteristically positive for cytokeratin 20, or CK20, showing a very specific dot-like paranuclear staining pattern. It's also positive for neurofilament protein. If it's CK20 positive, you are dealing with a primary Merkel cell tumor.
And the surgical approach. I know we cannot treat this like a standard low-risk SEC. The biology is too aggressive.
Absolutely not. You must treat this with immense respect. The local aggressiveness and the metastatic potential are immense. About 55% of these patients will develop regional lymph node metastases.
Wow, over half.
Yeah. Because of this high propensity for spread, the surgical management of the primary tumor demands highly aggressive, wide local excision. The recommended margins are a massive 2 to 3 centimeters of normal tissue, going deep to the fascia. You are managing the primary excision of a Merkel cell tumor similarly to, or even more aggressively than, a thick, invasive melanoma.
Which brings us to the deadliest skin cancer of all, malignant melanoma. This is an entirely different beast. With BCCs and SCCs, we largely base our margins on a clinical gestalt of size and location. With melanoma, the staging dictates a highly specific, algorithmic protocol of surgical margins and regional nodal management.
It's very protocol-driven.
Let's start with the basics. What are the major risk factors for melanoma, and what is the underlying genetic pathway we need to understand?
The risk factors are expansive, but you can neatly package them for an examiner using the mnemonic P parents. Let's break that down.
Okay, let's hear it.
P is for premalignant lesions, like giant congenital naivety. The second P is for previous melanoma. Having one melanoma drastically increases your risk of a second primary. A is for age. Risk increases as we get older due to cumulative DNA damage. R is for race. Caucasian populations have a vastly higher incidence than darker-skinned populations. E is for economic status.
Let's pause on the E. We all memorize the P parents mnemonic, but economic status seems counterintuitive. Why would affluent populations have a higher risk of a skin cancer?
It does seem odd until you look at the historical behavioral data. Historically, affluent populations in the UK and Northern Europe were the ones who could afford to take foreign holidays to tropical, high UV environments before sun awareness campaigns were prevalent.
Oh, right, binge tanning.
Exactly. They experienced intense, intermittent bursts of intense sun exposure, resulting in severe childhood sunburns, which is a massive driver for melanoma later in life.
That makes perfect sense. Let's finish the mnemonic.
Right. N is for naivety. Specifically, having a high burden of naivety more than 50 ordinary moles, or having familial atypical mole syndrome. T is for type of skin, specifically Fitzpatrick skin types 1 and 2. Those are people who burn easily and never tan. And finally, S is for sunburns, particularly blistering sunburns during childhood.
And the biology, the genetic pathway.
Biologically, the critical genetic pathway you must understand is the MAPK, or mitogen-activated protein kinase, cell signaling pathway. About 50% of all melanomas carry a very specific mutation in the BRAF gene, most commonly the BRAF V600E mutation.
What does that mutation actually do in the cell?
The BRAF kinase is a crucial relay switch in the MAPK pathway, telling the cell to grow and divide. Normally, it only turns on when it receives an external signal, but the V600E mutation locks the switch in the on position.
It's jammed.
Exactly. It causes constitutive, uncontrolled activation of the pathway, driving continuous tumor proliferation and survival, completely independent of any external growth signals.
Okay, so a patient comes into your clinic with a suspicious, asymmetrical, irregular pigmented lesion. You have done your initial excision biopsy with a tight 2 mm margin just to get the tissue to the lab. A week later, the pathology report confirms malignant melanoma and gives you the critical number, the Breslow thickness.
The most important number.
How do we determine the definitive wide local excision margin? And for the boards, you cannot just list the numbers. You must know the historical trial data that proved those numbers.
You absolutely do. This is a favorite topic for examiners because it demonstrates the evolution of evidence-based surgery. Our current margin guidelines are not arbitrary. They are hard-won from major, decades-long, randomized controlled trials. We have to look at the history.
Right, because historically it was pretty barbaric.
For a long time, the surgical dogma was radical. Surgeons were taking massive 3, 4, or even 5 centimeter margins for every single melanoma, regardless of how thin it was.
That is an immense amount of tissue to remove. I mean, a 5 centimeter margin in every direction creates a 10 centimeter wide defect. You cannot just close that. Every patient was getting massive skin grafts, enduring huge donor site morbidity, prolonged hospital stays, and terrible cosmetic outcomes.
Exactly. The morbidity was staggering. So the surgical community had to ask, are these massive margins actually saving lives, or are we just mutilating patients for no oncological benefit? This led to the landmark trials.
Let's walk through them.
First, the WHO Cooperative Group trial. They looked at thin melanomas, less than 2 millimeters thick. They randomized patients to either a 1 centimeter margin or a traditional 3 centimeter margin. They found absolutely zero difference in overall survival or local recurrence. That was the first major paradigm shift.
What about thicker tumors?
Then came the intergroup melanoma surgical trial. They looked at intermediate melanomas, between 1 or 4 millimeters thick. They randomized them to either a 2 centimeter or a 4 centimeter margin. Again, no difference in overall survival. The Swedish trial confirmed this, finding no difference in survival between 2 centimeter and massive 5 centimeter margins for intermediate melanomas. And finally, the French trial echoed all of this, showing 2 centimeters was safe for tumors under 2.1 millimeters.
So all of that robust international data consolidated into the current UK guidelines that we use today. Let's list the exact margins based on Breslow thickness.
Okay, here are the numbers. If the pathology shows melanoma in situ, meaning the atypical cells are confined entirely to the epidermis and have not breached the basement membrane, you take a 0.5 centimeter margin.
Under 1 millimeter.
If the Breslow thickness is less than 1 millimeter, you take a 1 centimeter margin. If it is between 1.01 and 2.0 millimeters thick, you take a 1 to 2 centimeter margin. And if it is a thick melanoma greater than 2 millimeters, you take a 2 to 3 centimeter margin.
And there's a specific rule for depth, right?
Yes. Crucially, a point often tested. Regardless of the peripheral margin width, the deep margin for all definitive wide local excisions must go all the way down to, but not include, the underlying deep muscular fascia.
Now we have to address the regional lymph nodes. The primary tumor is excised, but what about the invisible spread? How do we manage the clinically node-negative patient? A patient where you feel their armpit or their groin and everything feels completely normal. Again, historically, we used to just take out all the nodes just in case, right?
Yes, the procedure was called elective lymph node dissection, or ELND. The logic was preemptive strikes. If the cancer is going to spread there eventually, let's just take the whole nodal basin out right now.
But that had major consequences.
Major trials eventually proved that performing an ELND offered no overall survival benefit for the majority of patients. And the cost was immense. Removing an entire nodal basin causes massive lifelong morbidity, severe lymphedema, nerve damage, chronic pain, and recurrent infections.
So we stopped doing it routinely.
Right. Subjecting every patient to an ELND is no longer the standard of care. Instead, we shifted to sentinel lymph node biopsy, or SLNB. We use this targeted approach for staging patients who have a Breslow thickness of 1 millimeter or greater, or those with thinner melanomas that show aggressive features like ulceration.
Let's talk about the trial that cemented this practice, the MSLT-1 trial, the multi-center selective lymphadenectomy trial. This is arguably the most important paper in modern melanoma surgery. What did it actually prove regarding SLNB?
MSLT-1 is a landmark trial you must be able to quote and explain. They took patients with intermediate thickness melanomas and randomized them into two groups. Group 1 got a wide local excision, and we just observed their lymph nodes clinically. Group 2 got a wide local excision plus a sentinel lymph node biopsy.
What were the findings?
First and foremost, the trial definitively proved that the status of the sentinel node is the single most important prognostic factor for predicting disease recurrence and overall survival. The numbers are stark.
Give us the numbers.
Patients who had a positive sentinel node, meaning microscopic melanoma, was found had a 62% 10-year survival rate. Compare that to an 85% 10-year survival rate for patients whose sentinel node was completely negative.
So it is an incredibly powerful prognostic crystal ball. But here's the nuance examiners will press you on. Did doing the biopsy procedure actually save the patient's life? Did the SLNB group live longer than the observation group overall?
That is exactly the nuance you must understand. For the whole cohort combined, performing a sentinel lymph node biopsy did not definitively improve overall melanoma-specific survival compared to observation. It is, fundamentally, a highly accurate staging tool.
But wait, wasn't there a benefit for the positive patients?
Yes. However, for the specific subset of patients who actually had node-positive disease, there was a clear survival advantage to finding it early. The node-positive patients in the SLNB group who were diagnosed microscopically and had an immediate completion lymphadenectomy had a 62% 10-year survival.
And the observation group?
The patients in the observation group who waited until their microscopic disease grew into large, clinically palpable lumps before having surgery only had a 42% 10-year survival. Finding it early and acting on it matters.
What's fascinating here is the physiological premise that makes SLNB work in the first place. It relies entirely on the assumption that lymphatic drainage from the skin primary maps in a predictable sequential order. The tumor won't just dump cells randomly into a whole cluster of 50 nodes. It will metastasize to one specific first echelon sentinel node first before the disease spills over into the rest of the nodal basin.
It's an elegant physiological concept,
Yeah.
and we exploit that sequential drainage practically in the operating room. We use dual modality mapping.
Walk us through the procedure.
Preoperatively, nuclear medicine physicians inject a radioactive technetium tracer around the tumor site to perform a lymphoscintigraphy, mapping the pathway. Then, intraoperatively, the surgeon injects a vital blue dye. We make a small incision in the axilla or groin and use a handheld gamma camera to physically hunt down that first radioactive blue-stained node. We take out just that one node and send it to pathology.
Which brings us perfectly to the anatomy of regional nodal dissections. If that sentinel lymph node comes back positive for micrometastases, or if a patient presents on day one with a massive clinically palpable lymph node, you're going back to the operating room for a completion lymphadenectomy. You are taking out the entire basin. This is major high-stakes surgery, and the board examiners will torture you on the boundaries.
Oh, they love anatomical boundaries.
Let's visualize it. Imagine you are staring into an open axilla. What are the strict boundaries and critical structures at risk during a complete axillary dissection?
You need to be able to verbally construct the axilla as a three-dimensional box for the examiner. The boundaries are strict. The apex of the axilla is a bony triangle formed by the convergence of the first rib, the clavicle, and the superior border of the scapula.
That's the top. What about the front?
The anterior wall is muscular and fascial. The pectoralis major, the pectoralis minor beneath it, and the clavipectoral fascia. The posterior wall is formed by the subscapularis muscle superiorly and the tremajor and latissimus dorsi muscles inferiorly.
And the medial wall?
The medial wall is the chest wall itself. The first four ribs, the intercostal muscles, and the serratus anterior muscle draped over them. A proper oncological completion dissection requires the removal of all fibrofatty lymphatic tissue from Berg levels first 2 and 3.
Define the Berg levels for us.
These levels are defined anatomically relative to the pectoralis minor muscle. Level 1 is infralateral to the muscle, level 2 is directly posterior to it, and level 3 is supromedial to it, extending right up to the apex.
Let me visualize that. So the medial wall is just the rib cage and the serratus anterior. That means my blade and my retractors are right up against some extremely delicate nerves. You cannot afford to sever these. What are the specific nerves at risk?
Well, the major vessels, the axillary artery and vein, form your superior boundary. Most of the massive cords of the brachial plexus run superior and posterior to the vein, so they're relatively safe if you stay in the right plane. However, there are 4 specific nerves you must actively identify and protect in the axillary fat pad.
Let's list them.
First, the long thoracic nerve of Bell. This runs vertically straight down the medial wall, lying right on top of the serratus anterior muscle. If you sever this, you denervate the serratus, and the patient develops a classic winged scapula.
Which makes it hard for them to raise their arm.
Exactly, making it difficult to raise their arm above their shoulder. Second, the thoracodorsal nerve. This runs infralaterally to supply the latissimus dorsi. Third, the medial pectoral nerve.
That one's tricky.
It is highly vulnerable. It pierces the pectoralis minor. If you are doing a full level 3 clearance, you often have to forcefully retract or even divide the pectoralis minor muscle to gain access to the very top of the axilla. The medial pectoral nerve is in severe danger of traction injury or transection here.
And the last one.
Finally, the intercostobrachial nerve. This crosses horizontally straight through the middle of the axillary fat pad to provide sensation to the inner aspect of the upper arm. Because it runs right through the lymph nodes, it is frequently stretched or deliberately sacrificed during a thorough dissection.
Which explains the numbness.
Right. This is why the most common, almost universal postoperative complaint after an axillary clearance is permanent numbness along the inner arm.
Now let's jump down to the groin, the inguinal dissection. This is another area fraught with complications, especially wound breakdown and lymphedema. What are the boundaries of the femoral triangle, and what is the surgical debate over the extent of the dissection?
The groin dissection starts within the femoral triangle. The boundaries are the inguinal ligament acting as the superior roof. The medial border is the medial edge of the adductor longus muscle. The lateral border is the medial edge of the sartorius muscle. The floor of the triangle is formed by the pectineus and iliopsoas muscles.
And the vessels inside.
The neurovascular arrangement within this triangle is highly testable. From lateral to medial, you must follow the mnemonic Andy-Wyvan.
Navy-Wyvan. Break it down.
That stands for nerve, the femoral nerve. Artery, femoral artery. Vein, femoral vein. Y-fronts, which represents the empty space where the femoral canal containing the deep lymphatics, and then moving medially out of the sheath, another vein, artery, and nerve.
And the major debate, how far up do we go?
The debate centers on whether to perform just a superficial inguinal dissection, which means you stop your dissection at the inguinal ligament and only clear the nodes in the femoral triangle, or whether you must proceed to an ilioinguinal dissection.
Going into the pelvis.
Right. An ilioinguinal dissection means you divide the inguinal ligament, enter the retroperitoneal space of the pelvis, and clear out the external iliac and obturator lymph nodes lying along the major pelvic vessels.
Entering the pelvis turns a morbid operation into a massively morbid one. When is it definitively indicated to go into the pelvis?
You must consider entering the pelvis if there is clinical or radiological evidence, like a CT scan showing multiple enlarged nodes, a fixed conglomerate mass of nodes, or, crucially, microscopic or macroscopic involvement of Cloquet's node.
Let's define Cloquet's node for the listener.
Cloquet's node, also known as the node of Rosenmüller, is the highest deep inguinal lymph node. It sits right inside the femoral canal underneath the inguinal ligament. It is the gateway between the leg and the pelvis.
So it's the sentry at the border.
Exactly. During a standard superficial groin dissection, the surgeon will specifically identify and send Cloquet's node for frozen section pathology while the patient is still asleep. If Cloquet's is positive, it means the melanoma has marched right up to the door of the pelvis and the disease has likely already spread into the iliac system. At that point, you must open the pelvis.
Let's talk about what happens when surgery simply isn't enough. Stage 4 metastatic melanoma, where the cancer has spread to the lungs, liver, or brain. 10 or 15 years ago, a diagnosis of stage 3 melanoma was essentially a rapid death sentence. How has the landscape of systemic therapy changed? It used to be just traditional chemotherapy like dacarbazine, which was essentially toxic and offered virtually no overall survival benefit.
The landscape has been utterly revolutionized over the last decade by 2 completely novel classes of drugs, immunotherapies and targeted signal transduction inhibitors. These have changed stage 3 melanoma from an acute, fatal disease into, for many patients, a manageable chronic condition.
Let's look at immunotherapy first.
The major breakthrough was ipilimumab. It is a monoclonal antibody that inhibits a receptor called CTLA-4. To understand this, you have to realize that tumors often evade the immune system by manipulating immune checkpoints.
How does CTLA-4 work normally?
Normally, CTLA-4 acts as an essential brake on the immune system, down-regulating T-cell activation so we don't develop massive autoimmune diseases. The melanoma exploits this brake to hide. By administering ipilimumab, you are inhibiting the inhibitor.
So you take the brakes off.
You are essentially cutting the brake lines on the immune system, allowing the patient's own cytotoxic T cells to become hyperactivated and aggressively hunt down and destroy the metastatic melanoma cells wherever they are in the body.
That is immunotherapy. What about the other pillar, the targeted therapies?
The other major pillar is targeted therapy, specifically drugs like vemurafenib. This drug is a masterpiece of rational drug design. It specifically targets the mutated form of the BRAF kinase that we discussed earlier, the BRAF V600E mutation. It binds to the mutated kinase and shuts down the hyperactive MAPK signaling pathway, effectively starving the tumor of its growth signal.
Here's where it gets really interesting, or where as a surgeon, you can literally kill a patient if you aren't paying attention to the biology.
Oh, absolutely.
If a patient lacks the BRAF V600 mutation, meaning their tumor has wild type, normal BRAF giving them vemurafenib is a catastrophe. It actually stimulates tumor growth. The drug paradoxically activates the MAPK pathway in cells that do not have the mutation. It proves exactly why genetic tissue testing of the excised tumor is an absolute non-negotiable prerequisite before initiating targeted systemic therapy. You cannot just throw vemurafenib at a stage IV patient and hope for the best.
It's molecular fuel to the fire if they don't have the mutation.
Exactly. Furthermore, there is a massive surgical implication here. Even in patients who do have the BRAF mutation, the drug paradoxically increases their risk of developing entirely different secondary skin cancers. They frequently erupt with multiple keratoacantomas and cutaneous squamous cell carcinomas, which you, the plastic surgeon, then have to rapidly and repeatedly surgically excise while the patient is trying to survive their melanoma treatment.
It perfectly illustrates how intertwined genetics, medical oncology, and surgical oncology have become. You are no longer just the person who cuts the lump out. You have to constantly monitor the entirety of their skin while they are on these targeted therapies, managing the complications of the cure.
That is a perfect segue away from oncology entirely into a completely different realm of pathology where getting the diagnosis wrong is equally catastrophic. Let's discuss vascular anomalies. Board exams heavily test the 2014 ISSVA classification.
They test it constantly.
And the reason they hammered this is simple. Misdiagnosing a vascular malformation as a vascular tumor leads to massive surgical errors and uncontrollable intraoperative bleeding. How do we clinically and biologically separate vascular tumors from vascular malformations?
The fundamental distinction in the ISSVA classification is biological behavior and cellular turnover. Vascular tumors, the most common being the infantile hemangioma, are true neoplasms. They undergo a period of active, aggressive cellular proliferation. They grow because the endothelial cells lining the blood vessels are rapidly dividing and multiplying.
And malformations.
Vascular malformations, on the other hand, are structural dysplastic defects in the morphogenesis of the capillary, venous, lymphatic, or arterial systems. They are embryological errors. They are present at birth, even if they are too deep to be visible initially, and they grow proportionally with the child. Crucially, they do not undergo rapid endothelial proliferation, and unlike hemangiomas, they do not ever spontaneously regress.
Let's map out the life cycle of the most common vascular tumor, the infantile hemangioma. What are the three phases?
An infantile hemangioma follows a very predictable triphasic life cycle. First is a proliferating phase, which typically occurs over the first 6 to 8 months of life. The tumor appears rapidly. It becomes deep red, bosselated, and raised above the skin, often described as looking like a strawberry.
And what's driving that?
This phase is driven by massive, rapid endothelial cell division, strongly upregulated by angiogenic factors like VEGF and basic fibroblast growth factor. Crucially, for the board exam, these proliferating cells strongly express GLUT1.
GLUT1.
Right. GLUT1 is a glucose transporter typically only found in the placenta and the blood-brain barrier. Its presence is diagnostic for an infantile hemangioma.
What's the next phase?
Second is the involuting phase, which is a prolonged period lasting from age 1 up to around age 5 to 10. The intense angiogenesis is suppressed. The bright red color slowly fades to a dull purple or gray, the tumor softens, and the dense vascular channels are slowly replaced by a loose fibrofatty stroma.
And the final phase.
Finally, the involuted phase. The general clinical rule of thumb, to quote, is that 50% of these tumors are fully involuted by age 5, 70% by age 7, and nearly 100% by age 10 to 12. They leave behind a residual mass of loose, bulky, fibrofatty tissue, often covered by thin, damaged crepe-like skin.
So the vast majority of these just need reassurance and observation. But what happens if a rapidly proliferating hemangioma starts obstructing a vital structure? For instance, a massive periorbital hemangioma blocking the visual axis and threatening to cause permanent amblyopia, or a subglottic hemangioma obstructing the infant's airway. What is the first-line pharmacological treatment?
The gold standard treatment has shifted entirely away from systemic steroids and is now firmly propranolol, a non-selective beta blocker. The discovery of its efficacy is one of the great serendipitous moments in modern medicine.
How did they find out?
In 2008, a French group was treating pediatric cardiac patients with propranolol for heart issues, and they coincidentally noticed that the infants' incidental hemangiomas were rapidly shrinking and blanching. Propranolol works through three main mechanisms. It causes immediate vasoconstriction, it decreases the expression of VEGF to halt angiogenesis, and it actually triggers early apoptosis or programmed cell death of the proliferating capillary endothelial cells.
But administering a systemic beta blocker to a tiny infant is not without significant risk. You cannot just prescribe it blindly.
Absolutely not. You must screen these infants meticulously. Severe contraindications include any underlying cardiac arrhythmias like heart block or sinus bradycardia. Propranolol can also blunt the physiological response to low blood sugar, creating a risk of profound, unheralded hypoglycemia.
And there's a specific syndrome to watch out for, right?
Yes, you also have to be incredibly careful in patients with syndromic hemangiomas, specifically Faces syndrome. Faces involves large facial hemangiomas combined with severe underlying structural arterial anomalies in the brain. If you induce systemic beta blockade and drop their blood pressure, you might critically compromise cerebral perfusion and cause an ischemic stroke.
You also need to distinguish between typical hemangioma bleeding, which can usually be stopped with simple pressure, and a true hematological crisis. What is the Kasabach-Merritt phenomenon?
This is a classic textbook board trap. Examiners will describe a massive infantile hemangioma and ask if Kasabach-Merritt is a risk. The answer is unequivocally no. Kasabach-Merritt phenomenon does not occur with common infantile hemangiomas.
What does it occur with?
It is a rare, acute, life-threatening consumptive coagulopathy associated specifically with two very rare, highly aggressive vascular tumors, caposiform hemangioendothelioma and tufted angioma.
What happens physiologically in Kasabach-Merritt?
The architecture of these specific tumors acts like a sieve. As the tumor rapidly enlarges, it physically traps circulating platelets within its tortuous vascular channels. This mechanical trapping leads to profound, sudden thrombocytopenia, hypofibrinogenemia, and the depletion of coagulation factors.
So they bleed out.
The infant is suddenly at a massive risk of spontaneous, catastrophic internal hemorrhage, particularly intracranial bleeding. It requires immediate pediatric intensive care management, aggressive hematological support, and often medications like vincristine or sirolimus, not just a simple dose of propranolol.
Excellent clarification. Let's look at the other side of the ISSVA classification, the vascular malformations. We have capillary, venous, lymphatic, and arteriovenous malformations. What are their distinct clinical presentations, syndromic associations, and modern treatments?
Let's take them sequentially based on flow dynamics. First, capillary malformations, commonly known as port wine stains. These are flat red or purple macules present from birth. They do not proliferate, but they do darken and thicken over decades.
And the syndrome association.
If a capillary malformation occurs on the face, specifically following the V1 ophthalmic distribution of the trigeminal nerve, you must urgently rule out Sturge-Weber syndrome. Sturge-Weber features the facial port wine stain, coupled with ipsilateral leptomeningeal vascular anomalies in the brain, leading to seizures, intellectual disability, and a very high risk of glaucoma. The standard treatment for the cutaneous component is serial treatments with vascular lasers, specifically the pulse dye laser, which selectively destroys the abnormal superficial capillaries.
What about venous malformations? These are notoriously difficult to manage.
Venous malformations, or VMs, present as soft, highly compressible blue masses. They swell significantly when the limb or face is dependent and they empty when elevated. Because blood pools sluggishly inside them, they often develop localized clots, which calcify into hard, painful little stones called phleboliths.
And the associated syndrome.
If a patient presents with multiple cutaneous venous malformations, you must think of blue rubber bleb nevus syndrome.
Why is that syndrome so dangerous?
Because the cutaneous blegs are mirrored by hundreds of fragile venous malformations lining the entirety of their gastrointestinal tract. This carries a massive risk of chronic anemia or sudden fatal gastrointestinal bleeding. For standard, isolated, large VMs, the primary treatment is usually not surgery. Surgical excision is bloody and often incomplete. The first-line treatment is image-guided sclerotherapy.
Who does that?
Interventional radiologists inject a sclerosing agent, often absolute ethanol or sodium tetracetyl sulfate, directly into the lesion under fluoroscopic guidance. The chemical aggressively destroys the venous endothelium, causing the malformation to clot, scar down, and shrink.
Moving on to lymphatic malformations.
Lymphatic malformations are cystic masses, classified morphologically as either microcystic or macrocystic. They are spongy and fluctuate in size. They can suddenly and dramatically swell if the patient gets a systemic viral illness, if the cysts bleed internally, or they become infected. Like venous malformations, the first-line treatment for large macrocystic lesions is often intralesional sclerotherapy.
And finally, the most dangerous, terrifying lesions in this entire category. The arteriovenous malformations, or AVMs.
AVMs are high-flow, fast-flow lesions. They are an anatomical disaster. They contain a central nidus, which is a tangled nest of dysplastic vessels. This nidus acts as a direct shunt, dumping high-pressure, high-volume arterial blood directly into thin-walled, low-pressure veins, completely bypassing the normal capillary bed.
And they get worse over time, right?
They are staged clinically using the Schobinger system, which charts their inevitable progression. Stage 1 is quiescence. In childhood, it might just look like a warm, pink stain, often misdiagnosed as a capillary malformation. Stage 2 is expansion. During puberty or pregnancy, hormonal changes cause the shunt to widen. You get a palpable pulsating mass. You can feel a mechanical thrill and hear a rushing bruit with your stethoscope.
What's stage 3?
Stage 3 is destruction. The massive shunting starves the overlying skin of oxygen, resulting in painful ischemic skin ulceration, tissue necrosis, and massive life-threatening external bleeding episodes. Stage 4 is decompensation. The volume of blood shunting directly back to the heart is so massive that the patient develops high-output cardiac failure.
Treating these is a surgeon's nightmare. The instinct when you see a bleeding AVM is to just find the main feeding artery proximal to the mass and tie it off, but you cannot just ligate the feeding artery, right?
Exactly. Proximal ligation is a catastrophic error. If you proximally ligate the feeding artery, you do not cure the nidus. The nidus senses the drop in pressure and instantly recruits dozens of microscopic collateral vessels from surrounding healthy tissue, making the lesion vastly more complex, more expansive, and infinitely harder to treat.
And you burn a bridge.
Right. Worse, by tying off the main artery, you have completely destroyed the interventional radiologist's future endovascular access route. The current protocol requires incredible multidisciplinary coordination. It involves super-selective angiographic embolization. The radiologist threads a microcatheter right into the exact center of the nidus and blocks it with glue or coils.
And then we operate.
Then, within 24 to 72 hours before the collaterals have time to recruit, the plastic surgeon must perform a massive, radical surgical resection of all the involved tissue. And even with this aggressive combined approach, a true curative resection is rarely achieved. The recurrence rates are punishingly high.
We have covered an immense amount of ground. We are moving into our final major topic, soft tissue tumors, specifically the sarcomas. We are tackling the mesodermal malignancies. Sarcomas are rare, making up only about 1% of all adult malignancies, but mishandling the initial presentation and the biopsy is a classic catastrophic board failure. What are the 4 cardinal clinical features of a soft tissue sarcoma, and why is the instinct to perform a simple open biopsy a massive mistake?
Any soft tissue mass is highly suspicious for a sarcoma if it meets any of these 4 cardinal clinical criteria. Number 1, it is greater than 5 centimeters in diameter, roughly the size of a golf ball. Number 2, it is located deep to the deep muscular fascia. Number 3, it is clinically painful. Number 4, it is actively increasing in size.
So large, deep, painful, growing.
The more of these features present, the higher the index of suspicion must be. Now, regarding the biopsy, imagine a general surgeon or a primary care physician sees a 6-centimeter lump in a patient's thigh. They think it's a lipoma. They decide to do a quick open excisional biopsy under local anesthesia, just cutting down into the mass to shell it out and see what it is. If that mass is a sarcoma, they have just committed a major limb-threatening oncological error
Why is it so disastrous?
because sarcomas are highly pressurized tumors. They are like a shaken can of soda. The moment you open the capsule with a scalpel, the pressure releases and malignant cells spill out, heavily contaminating the entire surgical bed, the skin edges, and the subcutaneous fat.
And you break the compartments.
Furthermore, an unplanned open excision almost always transgresses natural anatomical compartment boundaries. You open facial planes that were previously protecting the rest of the leg. You effectively upstage the tumor instantly. Because of that contamination, when the reconstructive oncologist finally gets the patient, they are forced to perform a vastly more radical resection, removing a massive block of contaminated tissue, sometimes leading to amputation, just to clear the field created by that careless first biopsy.
So what is the gold standard approach?
The gold standard is a percutaneous core needle biopsy, directed by ultrasound or MRI. It must be performed at a specialist sarcoma center. And critically, the needle track must be carefully planned and placed exactly along the line of the planned future surgical incision.
Why is that?
This ensures that the entire biopsy tract, which is potentially seeded with tumor cells, can be cleanly excised en bloc along with the main tumor during the definitive resection.
Let's talk about the anatomy of the tumor itself. Explain the concept of the pseudocapsule. Why is it a trap, and how does it dictate our surgical approach? Break down the ANKI classification for surgical margins.
Because a sarcoma expands centrifugally, pushing outward in all directions, it crushes and compresses the surrounding normal muscle and soft tissue into a dense reactive zone called a pseudocapsule. To an untrained surgeon, this pseudocapsule looks like a perfect, glistening white dissection plane. The tumor feels like it desperately wants to just shell out cleanly.
But it's not a real capsule.
No, it is a trap. This pseudocapsule is not a true barrier. It is completely permeated with microscopic fingers of tumor, and beyond it lie skip lesions, isolated clusters of tumor cells floating in the normal muscle nearby.
So how does ANKI classify the margins based on that?
The ANKI classification defines the oncological adequacy of your margin based on this anatomy. Let's walk through the 4 levels. First, an intralesional margin. This is a disaster. This is when the surgeon inadvertently cuts through the pseudocapsule and shells the tumor out from inside it. Macroscopic, visible tumor is left behind in the patient, and the recurrence rate is nearly 100%.
Level 2.
Second is a marginal excision. The surgeon dissects right along the outer edge of the pseudocapsule. The visible tumor is gone, but the microscopic fingers and skip lesions are left behind. The local recurrence rate is unacceptably high, around 40 to 60%.
And the third?
Third is a wide excision. This is our standard oncological goal. The surgeon completely ignores the pseudocapsule. They remove the tumor, the pseudocapsule, and a generous, continuous cuff of completely normal, healthy, non-reactive tissue in all directions. With a true wide excision, local recurrence drops dramatically to about 10%.
And finally, radical.
Finally, a radical margin. This means you remove the entire anatomical muscular compartment from its tendinous origin to its insertion. Local recurrence is near zero, but the functional morbidity to the limb is massive.
So what does this all mean for these specific subtypes that plastic surgeons are routinely called upon to manage? We frequently deal with dermatofibrosarcoma protuberans, or DFSP, on the trunk, and occasionally we are called into complex orthopedic cases to reconstruct massive bone sarcomas. Walk us through those 2 scenarios.
DFSP is a highly unique soft tissue tumor. It is classified as an intermediate malignancy. It rarely metastasizes to lymph nodes or distant organs, but it is incredibly relentlessly locally aggressive. It typically presents as a slow-growing, indurated red-brown plaque or nodular mass, most commonly on the trunk.
And the genetics.
Genetically, you must know that it is driven by a very specific translocation between chromosomes 17 and 22. This translocation fuses 2 genes, COL1A1 and PDGFB, leading to massive overproduction of a growth factor that drives the tumor.
And surgically, it's very tricky.
Surgically, DFSP is a nightmare because its microscopic tentacles spread far beyond the visible plaque, tracking along fascial planes like roots. Even when surgeons take aggressive wide margins of 2 to 3 centimeters circumferentially and dissect deeply right down to the deep fascia, the local recurrence rates remain frustratingly high.
So Mohs is used.
Yes, this is why Mohs micrographic surgery, or slow Mohs with paraffin-embedded sections, is increasingly favored for DFSP, mapping out those long asymmetrical roots to ensure clearance while sparing surrounding tissue.
And what if it is unresectable, or if it recurs multiple times? We have a targeted therapy for this too, don't we?
We do, and it links perfectly back to the genetics. Because DFSP is driven by that specific chromosome 17 and 22 translocation producing PDGF, tumors that are unresectable or recurrent respond brilliantly to imatinib. Imatinib is a tyrosine kinase inhibitor that specifically blocks the PDGF receptor. It shrinks the tumor dramatically, often making an inoperable tumor surgically resectable.
Now, let's talk about the massive orthopedic reconstructions. Bone sarcomas like osteosarcoma or Ewing's sarcoma in young adults. The orthopedic oncologists remove the tumor, but they leave a massive structural defect in the limb. Plastic surgeons are crucial for the limb salvage reconstruction. A classic, highly testable method is the Kapana technique. Describe how that intense multidisciplinary surgery works on the table.
The Campana technique is an incredible feat of surgical engineering and biology. It starts with the orthopedic oncologists. They resect the entire diaphysis, the long central shaft of the bone containing the tumor, let's say the femur. The patient now has a massive gap in their leg.
And what happens to the bone they took out?
The resected bone segment is taken to the back table. The gross tumor is physically scraped and reamed out of the hollow bone ex vivo. Then that remaining hollow autologous bone shell is wrapped in sterile towels and sent down to the radiation oncology department. It is treated with massive, lethal doses of extracorporeal irradiation about 90 gray.
Which would normally kill a limb.
This dose is high enough to completely obliterate every single remaining microscopic malignant cell. You could never give 90 gray to a living leg without destroying the skin and nerves. The bone is brought back to the OR. It is now a perfectly sterile, structurally matched, but biologically completely dead piece of bone graft.
You can't just put dead bone back in.
If you just screwed that dead bone back into the leg, it would never heal, it would get infected, and it would eventually crumble under the weight of walking because it has no blood supply.
And that is where the plastic surgeon steps in to bring it back to life.
Exactly. While the bone is being irradiated, the plastic surgery team is working on the patient's other leg. We harvest a free, vascularized fibula flap. We take a long segment of the fibula bone, entirely mobilized on its peroneal artery and vein blood supply.
So you have a living bone ready.
When the irradiated femoral shell comes back, we remount the center of it a little more, and we literally insert the living, vascularized fibula straight down the hollow middle of the dead bone shell, like a pencil inside a tube. The orthopedics team rigidly fixates the whole construct back into the thigh with massive plates and screws. Finally, the plastic surgeon takes the tiny peroneal vessels attached to the living fibula core and anastomoses them under the microscope to the major vessels in the thigh. So you have provided a living, pulsating biological core running to the center of a dead, irradiated structural shell. Precisely. Over months and years, that living fibula core slowly hypertrophies, and it physically revascularizes and creeping substitutes the dead, irradiated bone shell, integrating it fully into the patient's skeleton. It avoids amputation, utilizes the patient's exact anatomy, and achieves a robust, permanent biological reconstruction.
If we connect this highly complex mechanical reconstruction back to the bigger picture of everything we have discussed today, it is clear the entire field of surgical oncology is undergoing a massive evolutionary shift. We are slowly but surely moving away from an era defined purely by radical, destructive anatomical excisions toward an era dominated by highly targeted precision genomic therapies. Consider how the discovery of the BRAF mutation completely rewrote our melanoma protocols, shifting us away from massive margin resections and blind lymph node clearances. Or consider how imatinib transformed the management of DFSP from purely mutilating surgery into a medically manageable condition.
It is a profound shift. The future of plastic surgery board exams might actually test you more deeply on your understanding of cellular signaling pathways like the MAPK pathway, the hedgehog pathway, or mismatch repair genetics than on your memorization of arbitrary scalpel margins. As systemic immunotherapies and targeted inhibitors become more and more effective, our surgical interventions might paradoxically become less radically destructive. We will be focused more on managing the complex cutaneous complications of targeted therapies and on performing highly complex, function-preserving microsurgical reconstructions like the Kapana technique to restore quality of life after the medical oncologists have controlled the systemic disease.
That concludes our deep dive chapter summary into cutaneous oncology and soft tissue tumors. If you are prepping for your boards, leave us a comment or a question below on which complex topic you want us to tackle next. Keep hitting those MedSync ANKI cards to turn this passive listening into active recall, and we'll see you in the next one. Remember, the diagnostic waters may be incredibly muddy out there, but understanding the underlying genetics, the history of the evidence, and the functional anatomy is what gives you absolute clarity in the operating room.